Greetings from the All India Institute of Medical Sciences, New Delhi. Today I would be presenting my talk on MRI negative epilepsy surgery, and I am grateful to the Bangladesh Neurosurgical Society for having given me this opportunity. If you look at randomized trials in epilepsy surgery, the trial by Weeb et al. Is of course a landmark trial, and subsequently we were also fortunate enough to publish this paper in New England Journal of Medicine, where for the first time we have shown the efficacy of drug-resistant epilepsy being treated by surgery for children. This paper was a landmark paper and was considered among the top 10 papers for the year 2018 for NEJM. In epilepsy surgery, we have to understand that just one investigation is not enough. We have to do, apart from MRI, a host of other investigations, and a concordance between all these investigations is necessary before we reach to a decision to do surgery. Now, surgery becomes straightforward if MRI is positive, and these are the cases where the outcomes are also very good. But what do we do when the MRI is negative? So this is a strategy what we can do if the MRI is negative. The first strategy, of course, would be to try to convert the MRI negative into an MRI positive, and this could be done by providing or performing an MRI which is as per the epilepsy protocol. Now, one can see from this important study by McIntosh, which was published way back in 2004, that whenever we have a lesional epilepsy surgery, that is where the outcomes are the best. I apologize for this cluttered slide, but if you can see the slide or the area which is marked, one can see that if MRI is negative, one should again perform an MRI in the tertiary institute where the epilepsy surgery is being done routinely, an epilepsy protocol MRI. Now, these are the parameters of an MRI which is performed as per epilepsy surgery protocol, and this is very important to be done for any kind of MRI which is to be evaluated for epilepsy surgery, because the lesions which we see in epilepsy surgeries are very subtle. For instance, in this FLAIR sequence, which was done as per the epilepsy protocol, one can clearly make out the subtle cortical dysplasia which is there. This patient underwent more than 12 MRIs outside, which were all reported normal. Again, in this MRI, one can see that there is a subtle loss of gray-white matter junction in the base of the frontal lobe. This again could be made out on an epilepsy protocol MRI. It is thus important to do MRI with various sequences in order to detect any subtle lesions, thus trying to convert an MRI negative into an MRI positive pathology. In about 20% of the cases, by doing additional advanced investigations like PET MRI fusion or magnetoencephalography or ictal SPECT, one can again go back and detect subtle changes happening on MRI. Now, what does one do if despite doing all these MRI sequences, one does not still find a lesion? Under those circumstances, it's very important to go in for more advanced investigations like ictal SPECT and PET. In a landmark paper which we have published, we have shown that whenever the ictal SPECT and PET are concordant, it provides a very good predictive value, especially for extratemporal surgery. To quote an example, this is a 30-year-old male having about 25 to 30 seizures a day with a history of head injury. As it can be seen here, ictal SPECT as well as PET showed a hypodensity in the right frontal region, and this collaborated very well with the magnetoencephalography, even though MRI was negative. So in this case, we went ahead and did a resection based on the concordance between the ictal SPECT and the PET, and the patient had a class 1 outcome. The histopathology was a type 1C cortical dysplasia. Finally, what do we do if we do not reach to a conclusion till now? So these are truly MRI negative. Over here, we need to develop a very strong hypothesis if we can go in for invasive recording. Currently, we prefer doing stereoencephalography, which we have been doing at our institute since 2014, and as it can be seen, it is minimally invasive and it could be easily explained. The main indication for stereoencephalography include to verify a network. So if you have a subtle lesion, or which is not very well apparent on MRI, it could be confirmed by stereoencephalography. Sometimes you have a non-concordance like video EEG versus MRI or PET versus ictal SPECT and so on. And again, this could be decided by stereoencephalography. Again, it would be required for multiple lesions like tuberous sclerosis or bilateral mesial temporal sclerosis. Stereoencephalography is usually not successful in order to find a lesion which is MRI negative. So one needs to have a strong hypothesis before one goes in and performs an SEEG. So as can be seen here, the main advantages of SEEG is that they are extremely thin electrodes, they provide excellent recordings, and they could be easily explanted, so one doesn't have to go ahead and do another surgery. They could be explanted in ICU, and more recently we have been very successfully doing it with language mapping. Of course, the downsides are that there is a considerable time required if you do it without the assistance of the robot, and sometimes there could be challenges in language mapping, which I don't think is such a big challenge nowadays. So this is how we do the SEEG, by using a robotic system as well as an OARM. And it's important to know all the standard pathways before one can do SEEG, and there are all established areas where one can do the SEEG. So one has to remember that more is not better. So we feel that an optimum number of SEEG electrodes are 7 to 10, and if we exceed 15, I think the hypothesis is lost. It's unlikely that we are going to get any useful information. A 28-year-old lady presented with history of epilepsy for a duration of 13 years. She had two types of semiology. One was associated with an aura of chest discomfort and palpitations. There was a history of automatism involving bilateral hands followed by speech arrest. There was a consistent history of urinary incontinence. The other type of semiology began with head turned to the right side followed by secondary generalization. She was on 3 anti-epileptic drugs. Video EEG revealed rhythmic, sharp and slow wave discharges in bilateral frontotemporal channels, followed by polyspike and slow waves in the same region, predominantly on the right side. Here, spikes can be seen in FP2, T2 channels just prior to the rhythmic theta activity, but also can be seen in FP1 and T1 channels, followed by a progression of seizures in the bilateral anterior temporal channels. Multiple events were recorded, which were consistently similar with seizures arising from FP2 and T2, as well as FP1 and T1 channels, suggestive of bilateral temporal lobe onset. MRI brain was performed as per epilepsy protocol, and this did not reveal any focal lesions and was reported as normal. PET MRI co-registration revealed hypometabolism in the left temporal lobe. Ictal SPECT subtracted from interictal SPECT, called as SYSCON, showed localization to the left anterior and posterior basitemporal regions respectively. On further evaluation with magnetoencephalography, the Dana sequence showed tight clusters in bilateral temporoparietal regions. The Loretta, however, revealed localization to the left temporal lobe. Functional MRI for language showed bilateral representation of motor speech and word generation arising from bilateral inferior frontal gyrus. Both semantic memory and comprehension showed predominantly bold activation on the left side. Neuropsychological assessment revealed impaired visual memory. There was also impaired immediate recall on verbal memory, suggestive of predominantly right temporal lobe involvement. Summarizing, there was a left temporal localization, which was based on clinical semiology, PET and SPECT scans, and also magnetoencephalography. Video EEG and neuropsych examinations were equivocal, but in contrast, on the right side, the video EEG and neuropsychological assessment showed a predominant localization. In addition, We also considered insula and cingulate gyrus also. A total of 12 ECG electrodes were planned in bilateral temporal to include the anterior, middle, and posterior temporal lobes for both lateral and mesial structures. In addition, left basitemporal was planned based on the findings of SPECT, and bilateral cingulate and insula were also covered in view of ictal urinary incontinence. The patient is positioned supine with the head fixed with a Mayfield clamp and attached to a robotic arm to achieve rigid fixation. Alternatively, a Lexel frame B may be used as a head holder, which allows free space without hindering the robotic arm in cases of multiple bilateral implantations. In this way, it is better than the Mayfield clamp, and there is a scope for 3-point fixation for smooth registration. In addition, bone-based fiducials may also be used for registration. We routinely use 6-point facial skin-based laser registration. This is followed by mesh registration covering the nose and the forehead, followed by zigzag laser scanning of the forehead, and then manually scanning bilateral temple regions. Once the registration is complete, the accuracy check is performed for all the 6 facial points, and to correct the errors more than 1 millimeter by matching these points manually. If an error of more than 1 millimeter persists, repeat registration is to be performed. Following the registration with the O-arm, the patient is now draped. A twistal craniostomy of 2.1 millimeter diameter is performed using a pneumatic powered handheld drill. The robotic adapter is closely applied to the scalp and is directly drilled over the scalp without any scalp incision. While drilling, a stopper is tightened at appropriate length, accounting for the scalp and bone thickness, and this stopper prevents any inadvertent entry into the brain. An important point to consider is to place the robotic adapter close to the scalp to avoid any wobble of the drill bit. While drilling, the surgeon may very well appreciate the initial resistance while going through the bone, followed by a slight giveaway when entering the diploic space. This again is followed by a resistance while going through the inner cortex. The dura is now coagulated using dural monopolar coagulation. The anchor bolt is now inserted using a screwdriver. Various types of electrodes are available in the market, starting with for simple recording purpose to multimodal functions like recording, stimulation, and lesioning simultaneously. The appropriate length of the electrode is inserted and the cap is tightened over the bolt after removing the stylet. The final tightening secures the electrode and prevents any CSF leak. This is followed by an O-arm confirmation of the accuracy of electrode placement and is also co-registered with MRI. However, we do this only for one electrode in order to prevent excessive exposure to radiation. Accuracy check is performed after placing all electrodes with a thin slice CT scan performed post-operatively, which is then again co-registered with the MRI. The patient is monitored in the ICU till he develops at least 3 to 5 habitual seizures. We then perform the stimulation of the electrodes to confirm the findings. Here, the left anterior, middle, and posterior basitemporal, along with the amygdalar contacts, showed seizure activity. However, no activity was seen over the hippocampal contacts. Similar findings were noted on stimulation of electrodes. Based on these findings, a left-sided surgery was planned. Hippocampal sparing, lateral, temporal, neocortical, and amygdala resection was planned. Pre-resection electrocardiography showed grade 5 bursts of discharges, which after anterior temporal lobe resection reduced to grade 4. Further resection of the posterior basitemporal achieved a grade 3 electrocardiography. Following resection of the amygdala, grade 2 recordings were achieved. while recording with a strip electrode placed on hippocampus did not reveal any activity. Hence, the hippocampus was spared. Post-operative course was uneventful. CT scan brain showed a good resection cavity. Histopathology confirmed a type 1B cortical dysplasia, both in the neocortex and in the amygdalar specimen. The patient remains to be seizure-free at 1 year of follow-up. Thank you very much. We would like to thank and acknowledge all the members of the epilepsy surgery team, especially Dr. Manjari Tripathi, our chief neurologist, Dr. Ramesh Dodamani, my colleague, Dr. Sailesh Gaikwad from Department of Neuroradiology, Dr. C.S. Bal from Nuclear Medicine, along with Dr. Madhavi Tripathi, and our fellows and residents. Thank you very much.